next speaker needs no introduction to a veterinary audience, but for those of you who don't know him, Professor Wayne McIlwraith is one of our leading veterinary surgeons, and particularly in surgery and orthopedic surgery in the world. He is a University Distinguished Professor, Barbara Cox Anthony University Chair in Orthopedics, and is the Director of the Orthopedic Research Center at Colorado State University. Despite these titles, you should know that Wayne is a Kiwi. He's from New Zealand, graduated from Massey University, and then did his surgical residency in America, where he has continued to practice for longer than perhaps he cares to remember. Wayne is a past president of the American Association of Equine Practitioners, a past president of the American College of Veterinary Surgeons, and the Veterinary Orthopedic Society. Wayne is going to give us two presentations this morning. He's a practicing surgeon, but very uniquely, he has a great involvement with veterinary orthopedic research, and this makes him uniquely qualified to give us his views. And his first presentation is going to be what non-steroidal anti-inflammatory drugs are used for in private practice. Wayne, thank you.
Thank you, Tim, and thank you for the invitation. When I was first invited by Graham Cook to speak, I was intimidated, so I went and read a lot of the literature that I wasn't really up on with non-steroidals, and I remain intimidated. It's a difficult area to, and of course the dilemmas have been already posed by previous speakers. The other thing I need to clear up is some of you are confused by the New Zealand designation in the program and then Colorado State underneath, and the question is I'm proud to be associated with both countries, and I am an adjunct professor at Massey. So the question, just quick definitions, and Dr. Roberts covered this very well earlier. There's a couple of levels of definition just for completeness. The initial definition by Lees and Higgins, they pointed out that NSAIDs are sometimes defined as those substances other than steroids that suppress one or more components of the inflammatory system. And of course this broad definition would include not only aspirin-like drugs, but also newer drugs such as hyaluronan, polysulfated glycosaminoglycans, and PPS. So I think for the purposes today, everybody agrees that, that it's tends to be used more restrictively to describe anti-inflammatory agents that inhibit some component of the enzyme system that converts arachidonic acid into prostaglandins and thromboxane, as in this diagram and as was nicely shown by Colin previously. We use PG2 levels in the synovial fluid in our research, looking at different osteoarthritic drugs or anti-osteoarthritic drugs as a monitor, and there's a very close correlation between the PG2 levels and the degree of lameness. So they do act as a nice biomarker, objective biomarker of lameness. And this has been reviewed before by Steve May and Peter Lees, who's done a terrific amount of work in NSAIDs some time ago, and who Dr. Higgins, who was mentioned before, did his PhD with. Inflammation has also been defined by Dr. Roberts, but I like this definition: a succession of changes that occurs in a living tissue when it is injured, provided that the injury is not such a degree as at once to destroy its structure and vitality, as opposed to necrosis, which is the state of irreversible arrest of function and inseparable disorganization of the structure and living tissue. And the reason I thought it was rather good, it epitomizes what we're treating with NSAIDs, or particularly with the level of phenylbutazone or flunixin that might be proposed by some people regarding this meeting, in that we have reversible damage. If we have irreversible damage, if we have a badly injured tendon or a badly injured bone, obviously continued competition is out of the question. So we're talking about reversible change. And inflammation in the equine athlete is a consequence of trauma, and it can be single and direct, and it can be to any part of the limb, but it could be single and direct, such as we see here in this picture, or it can be associated with cyclic trauma, which is the more common way that we have injury, and is particularly important in the racehorse because we do know that this cyclic trauma leads to micro damage in the bone and in the cartilage, which can later lead to catastrophic injury. So really, I think the cyclic trauma, the low-grade or relatively low-grade inflammation, is what we're talking about today. Anyway, inflammation is an expected consequence of high-level activity in equine and human athletes. It's a common problem of the musculoskeletal system, typified by traumatic joint disease and osteoarthritis. I may be a little biased because this is the most common problem that we deal with in orthopedics, but I use as an example, that upper picture is showing an inflamed joint. This is what it looks like arthroscopically, and not only does the inflammation lead to direct pain, or sensitization to pain, but it also leads to the production of mediators that cause breakdown of the cartilage. And a lot of what we're treating, even though the trainer or the owner, the horse, of the horse may be wanting us to be able to go back and compete, this is what we're really treating in veterinary medicine, is trying to prevent the development of this loss of articular cartilage. So we have more than just an analgesic motive in mind when we're discussing this. But this cyclic trauma leads to these various other changes. Sorry, I was told to press it firmly, so we get 2 slides at once. It has been suggested that 60% of lameness problems are related to osteoarthritis, and I mainly point that out because it's consistent with the fact that we're not only treating inflammation for its direct functional effects, but also for the degradative effects, the long-term health of that joint is equally important. So it stresses the importance of advancements of both medical and surgical treatment options. And as has been clearly stated earlier by other speakers, the welfare of the horse is the priority in making the decisions of treatment. And that's appropriate. Now, there's going to be a test after this meeting, so you've all got to remember it. But I mainly put it up because there are many consequences to not treating inflammation. And just briefly, this is the synovial membrane, which is the lining of the joint, what I showed you to be inflamed before. Not only does it produce prostaglandins, which, as we'll come back to and has already been implied, do sensitize pain perception, but also we produce these various mediators that go into the cartilage and cause breakdown of the critical components of the articular cartilage. And articular cartilage is basically this Teflon coating over the surface of the joint. When it loses its proteoglycans, there's 2 big components that we worry about. Proteoglycans that provide the compressive stiffness. If we start losing that, the cartilage loses its ability to provide shock absorption. And the collagen, which holds it all together like a scaffold, and we get breakdown of that as well, and that's when we get erosion. That's when we see the various progressive changes that I showed you arthroscopically. Not only that, these mediators get in the bone. This is the bone underneath the cartilage. We call it the subchondral bone, and that can promote bone resorption. In racing, very critically, we now recognize that all of our fractures, all of our catastrophic fractures, start as subchondral micro damage in the bone. And so the early diagnosis and also the prevention of allowing a horse to race with micro damage is a critical issue that we face in trying to improve that situation. And I'll come back to that in a minute. This is a slide that I've had used a long time. It's from a PhD work many years ago. As Tim implied, it's been a few years. But the purple is staining the proteoglycans that keep our cartilage held together. And on the left-hand side of the slide, we have normal cartilage. On the right-hand side, this is cartilage taken from a joint that's had a period of 8 weeks of inflammation. And you can see that we're losing the purple stain, which is an indication of the proteoglycans going away, and we're starting to get disruption, morphologic change at the surface. And that is what, whenever we're treating, not just the pain, but we're also trying to prevent those events from occurring. So the targets for therapy in the horse are a number. Synovitis and capsulitis are common problems. And they do produce pain, and we now know that prostaglandins sensitize. I've got them there in red. There's a number of these products that develop. Pain is direct, can be direct, but joint effusion also contributes to pain because you've got a joint full of fluid. And then you've got these various mediators that are being produced here that you see. The veterinarian sees it manifest as an increased joint effusion in the joint, and here we see it in that situation if we look at it arthroscopically. Now, there's an interesting, there's a hierarchical control of inflammation. We've done a lot of work with gene therapy, and we've got some modern biological treatments that address the issue at the top of the cascade. There's a thing called interleukin-1 that acts on receptors of cells to cause discharge of these other mediators. Notice PG2 here is one of those critical factors in the prostaglandin cascade. We can provide therapies that will block, sorry, let's use the point. Sorry for this, I'm not handling this very well. If the therapeutic target is a cytokine, such as interleukin-1, we've got the potential for more side effects because we're stopping further up the cascade. I just wanted to point out that a drug-blocking cyclooxygenase, in other words, an NSAID such as phenylbutazone, affects prostaglandins alone, so it's more focused anti-inflammatory therapy, and that's why it's commonly used in practice. The use of NSAIDs, this is just a summary. I feel that it's been the standard of care for the first line of treatment for traumatically induced inflammation. I use it routinely pre and post orthopedic surgery. The phenylbutazone and flunixin, has been pointed out, are the most commonly used. There are newer COX-2 preferential inhibitors, and topical application is the latest evolution in these treatment options. It's important to emphasize that NSAIDs are not corticosteroids. A lot of the debate that we've had over the last 30 years, at least I've been aware of over the last 30 years in racing, has been the use of corticosteroids. Probably the potential for abuse there is more, but NSAIDs are obviously not. And the diagram that I showed before, I quickly passed over it, and Dr. Roberts pointed out, is that corticosteroids act higher up this cascade. So the use of NSAIDs in equine athletes during competition is a debate, and is obviously the debate today. It's been pointed out before. I thought these points that were made in a letter by Her Royal Highness Princess Haya herself that was published in The Horse, it was a letter to Leah Jeffcott, but these questions are the critical ones. Are NSAIDs performance enhancing in the equine athlete? I'm not going to go any further with that, but we've got good speakers this afternoon to discuss it. Is there a legitimate argument for the therapeutic use of equine athletes during competition? I hope I've shown some indication of that with pointing out the pathobiology of the problem. Are NSAIDs safe to use in the equine athlete? A good question. Is the FEI's blanket prohibition on the use of NSAIDs, that's my question, below the letter obviously, on the use of NSAIDs in equine athletes during competition best for the welfare of the horse? And Professor Touton pointed that out very, very well. The dilemma of what's best for the welfare of the horse versus the level playing field. That is an important issue. And I don't have the solutions here, but I want to provide a little bit of thought on it. We ask these athletes to do a lot. I have had some experience with FEI competition and assisting Wally Niederer with the New Zealand eventing team for a number of years, and I was initially quite surprised that we couldn't give any NSAIDs to a horse after a 4-star cross-country event. On the other hand, I had also got a lot of experience with racing and the racing issue and medication in the States, and had really fallen back to it doesn't really matter what we tell each other on therapeutic benefit, that the public will not accept anything, particularly the betting public. On the other hand, I was quite surprised to find that WADA permits the unrestricted use of NSAIDs during competition, whereas FEI prohibits the use at any level. And so that is quite a dilemma. in what we ask these horses to do. As far as actions on inflammatory processes, as were mentioned before, all NSAIDs inhibit cyclooxygenase to some degree. With phenylbutazone and flunixin, this effect is marked. On the other hand, some drugs, such as carprofen, are relatively weak COX inhibitors, so we presume that other mechanisms contribute to their overall anti-inflammatory activity. There's variations in the activity of different NSAIDs, which has been nicely pointed out before. The COX-1, cyclooxygenase 1 influencing normal physiologic functions, COX-2 having a role in inflammation, and it is therefore logical that specific inhibition of COX-2 would minimize the adverse effects, but at the appropriate doses, the ones that inhibit both, such as phenylbutazone and flunixin, are generally without side effects at the appropriate dose. On the other hand, we have recognized and continued, and the profession has had drugs become available that are more specific against it, and we should certainly look at it. I've used carprofen, for instance, in horses. These are not competition horses. These are horses that need phenylbutazone regularly, or at least NSAID activity regularly, and become intolerant to it by showing GI side effects or kidney side effects or both. Have been able to use these inhibitors, and they do make a difference. They do lessen the side effects that we face. So phenylbutazone has been mentioned before. It's the most widely used NSAID in horses. It can be given orally or intravenously, relatively non-toxic at repeated doses of 2.2 milligrams per kilogram, twice daily or less. A single dose has a half-life of approximately 5.5 hours. However, a single dose of 4.4 milligrams per kilogram markedly reduced PG2 and PGI2 production in exudate for up to 24 hours, leading to the implication that even though it may not be pharmacologically detectable or pharmacologically at a high level, it can still be effective in the peripheral tissue. And this has been explained by Lees et al. Of accumulation of phenylbutazone and inflammatory exudate, as is written here. And hence the recommendation, the commonly used recommendation for once daily dosing. This is just one example, and in my next talk I'm going to talk about, discuss the various studies that have been done regarding analgesia with phenylbutazone, but significant effect on lameness in horses with experimentally induced synovitis, that's synovitis like we showed before, lameness for 8 to 10 hours, as well as decrease in lameness for 8 to 10 hours, as well as these other outcome parameters. Flunixin, of course, is also used clinically, at this time at a dose of 1.1 milligrams per kilogram. Its half-life is relatively short. On the other hand, its onset of analgesia seems to persist for up to 30 hours, and that's been theorized to be associated with accumulation at an inflammatory foci, and this is responsible for the long duration of action. And we'll ignore that slide, it should be in the next talk. So what about the use of NSAIDs in racing? Recently with the Beaver announcement, this has been brought up as a reason for perhaps making particular policy at the FEI level. There's a tendency to extrapolate, and I think we can learn some lessons. Historically, the American Association of Equine Practitioners sponsored a racing summit on medication in 2001, which led to the formation of the Racing Medication Testing Consortium. We had another problem with a lot of disparity in rules and standards between states. Then along came the Barbaro and 8 Bells catastrophic injuries that highlighted the medication issue again. I had the dubious privilege of testifying before a congressional subcommittee about medication, and certainly the layman view was that it's all about medication. And I came back from that meeting feeling that we had to greatly change, at least change in the States. The AAP Racing Medication Task Force that was formed after 8 Bells injury has led to the development of white papers. And most recently, the RMTC has recommended lowering the permitted level of phenylbutazone from 5 to 2 milligrams. On the other hand, there's marked differences between racehorses and sport horses, and this is some data from Dr. Shoemaker who recently provided it, and he will talk about this in more detail tomorrow, but you can see there 2 per 1,000 starts in racing is an approximate figure based on data. Mary Scolay is here. She's been a large part of this database accumulation. USEF, on the other hand, had this so-called starts, but at least horses starting in events, and you can see the orthopedic injury rate is low. So I think we need to be careful with our extrapolation. Now, this is a statement that I only saw on Thursday last week from the British Equine Veterinary Association. Things like grave concerns that horses competing whilst under treatment with pain-relieving medicines are at an increased risk of musculoskeletal lesions progressing to catastrophic injury. It certainly applies to racing when there's relatively high levels of phenylbutazone, but does it apply to the sport horse? I'm very skeptical about that. And of course, catastrophic injury is not the same problem. We still have the welfare issues. We still have to decide or be comfortable with the fact that we don't place the horse at increased risk. The paper that's been quoted a lot is the one by Diracolu in Veterinary Pharmacology, and I think that this has certainly got a statement that certainly conclusion that the horses that had fatal injuries had a higher level of phenylbutazone in their in testing. On the other hand, certainly at the levels that we used, you can certainly cover up a pre-catastrophic injury. As I mentioned before, there's a lot of micro damage in horses, in race horses. But do we have that same level of micro damage in sport horses? I don't think so. It's really important that we consider one NSAID and one low dose is a lot different than the situation in Kentucky under the circumstances of that paper. There is some work, just briefly finishing up, on phenylbutazone, on bone activity and formation, but you'll note that in this particular study that was published out of Ohio State, 4.4 milligrams per kilogram twice a day, what we consider to be a very high dose for 14 days, showing some indication that we had reduced bone formation activity. So quickly on the negatives, there are a number. There's no intoxic effects, and I'll talk about the analgesic effects shortly. The thing that I wanted to sort of mention, and it was brought up in a previous talk, is that is it harmful to cartilage? The evidence is contradictory, but I did think that it was important to look at this study that was done recently in humans with MRI, comparing patients that were on non-steroidal anti-inflammatory drugs, both COX-2 inhibitors or general ones, and they did have evidence that the COX-2 inhibitors at least were protective against progression of cartilage erosion, and they captured greater cartilage volume. And which brings me to one recent study that we've done, and that is where we looked at a topical a topical NSAID in the joint. And the important thing is here, do we have disease-modifying effects? I think conventionally we know that we talk about symptom-modifying effects and disease-modifying effects. Disease-modifying effects is that you're making the health of the joint better. Whereas symptom-modifying is that's what you're doing. You're decreasing the pain, you're taking away the symptoms. And the interesting point in this study was that we showed marked inhibition of inflammation. On that left-hand slide is the control, and the right-hand slide is the topical diclofenac. And more importantly is that we did show that while there was slightly less, this is staining for the proteoglycans, those essential components we talked about before, while there's considerably less, while there is some less proteoglycan in the phenylbutazone group, the ones with topical non-steroidals, the topical non-steroidal had increased what we call saffron and O staining, which indicates a higher level of proteoglycan in the cartilage. So this is the first indication that I'm aware of that with the right NSAID we can potentially protect the cartilage. So there is some good news at the end of that in terms of the fact that we think we can help the state of the cartilage. And we should consider that when we're thinking of the long-term effects of using the other non-steroidals that perhaps are not COX-2 selective. Thank you.